people who live the longest have a total cholesterol of 240 to 260.
Right now, my guideline is if a total cholesterol is over 200, that gets my attention. If it's under 200, it honestly doesn't.
Yeah.
The only differentiation I'll make is if somebody has high small particle B, which has a tendency, it's a fractionation of the lipids that you can ask for. It can be run through regular labs, the LabCorp request. But when we fractionate those lipids and we see high small particle B, that's where I might be like, okay, I need to take this seriously because this has more of a tendency to form plaque and can be more of a risk. Am I correct in my thinking scientifically, or does that actually need some adjustment?
Look, our body makes cholesterol.
Right.
We have an enzyme. That's what the statin medication, they prevent the endogenous production of cholesterol. But we also get cholesterol from our diet. And so the body balances what it consumes through the diet versus what it needs to produce endogenously to maintain normal, optimal levels. So if you look at the Framingham study, right, which is the largest prospective clinical cohort, certainly in the U.S., probably maybe in the world, the people who live the longest have a total cholesterol of 240 to 260.
Okay, that gets no press.
Of course not. Unless you have a familiar cholesterolemia, hypercholesterolemia, and your total cholesterol is maybe 500 or 600, maybe you try to lower it. But again, cholesterol does not cause heart disease, so why target it? And I like the advanced lipid panels because if you looked at oxidized lipoproteins, if you look at the particle size and number, that has more bearing on diagnostic, prognostic utility than total cholesterol or total HDL, total LDL. To me, those are completely useless.
So what should we be screening for on our cardiovascular patients, or if we have, that kind of family history, what should we be screening for? I don't know how you feel about things like ApoB, Lp(a). These are all the questions I get over and over again.
No, I think they're certainly more clinically useful than total cholesterol. But, certainly myeloperoxidase. Elevated MPO is pretty good biomarker for susceptibility of plaque rupture. I still like the Lp(a), C-reactive protein, the amount of inflammation in the lining of the blood vessels. But me, it's all about vascular reactivity and endothelial function. Because when we look at the progression of cardiovascular disease, the onset and progression, what happens is, number one, you lose the barrier function in the endothelial cells. You lose the vascular reactivity because the endothelial cells produce nitric oxide, dilates the blood vessels, and then they also downregulate the adhesion molecules. So if your endothelial cells in your blood vessels are making sufficient nitric oxide, you have normal blood pressure, you have normal vasoreactivity, you downregulate the adhesion molecules, so you have less monocytes, neutrophils, macrophages, platelets that are sticking, you maintain the barrier function, and you have healthy blood vessels. You don't get smooth muscle hyperplasia, you don't get plaque deposition, and you're free of cardiovascular disease. So I think we need to focus on not just the biochemical biomarkers, but look at the functional
component of
function of the blood vessels. And we can do that through flow-mediated dilatation, look at the ischemic plethysmography, and look at how well do the blood vessels respond to certain agonists or stimuli. Because that tells you the function of the blood vessels and not kind of a static biochemical marker.
And that could be the fundamental issue that we're having, is that we're just looking at static markers rather than what's actually happening. Is there a way in the exam room to measure endothelial function and endothelial reactivity?
There's some FDA-cleared medical devices that look at what's called flow-mediated dilatation. And really, that's the gold standard. So you put a blood pressure cuff on the brachial artery, and you just pump it up to suprasystolic levels to where there's no inflow into the forearm. And you occlude that blood vessel for 5 minutes.
Okay.
And then you release it, and then you can look at the reactive hyperemia or the dilation of the brachial artery downstream. And if it dilates, then it tells us that blood vessel is making nitric oxide. It's responding to that brief period of hypoxia and ischemia, and your blood vessels are making nitric oxide. But when you release the cuff and there's no vasodilation, that tells us without a doubt those blood vessels aren't making nitric oxide.
But that's not something somebody can do at home, is right?
No,
just with a traditional cuff, you can't.
No, you have to either have an ultrasound, or there's some companies who use a fingertip probe. You can look at non-ischemic plethysmography and looking at pulse wave analysis, looking at the stiffness of the blood vessels and how fast that pulse wave travels with each heartbeat. But there's different devices out there that are functional measurements, and they're very, very useful and clinically relevant. Or you can look at symptoms, because what we're finding now is if you're deficient in nitric oxide, there's a hierarchy of symptoms. So number one, you start to develop erectile dysfunction.
Is that the first symptom?
That's usually the first symptom.
Wow. Okay.
Because think about it, if you can't dilate the blood vessels, the sex organs, because your body can't make nitric oxide, you don't get engorgement. You cannot get engorgement.
Right.
So in men, it's very simple. It's a blood flow problem. In women, sometimes it's hormonal, it's psychological. But again, it's a vascular issue. And 50% of the men over the age of 40 self-report ED. I think it's much higher because most men aren't going to self-report ED.
Right. But what about all the women who are coming in with low libido? Should I be thinking about it with them as well?
For sure.
Okay.
I mean, but again, I think nitric oxide is what we call foundational.
Okay.
Right? So when we restore nitric oxide, you're still going to have to address
All the
other
other
hormone
things.
deficiencies. But I think it's foundational to start there.